things, but lung, again, remains the most common. And it's a very poorly understood disease. And one of the reasons for that is that it is comparatively so rare. And only recently has some of the so-called biology of the disease been investigated. I wouldn't say that it's been worked out, but some of the mutations that are thought to play a role in this disease have started to be identified. The mutation that's the most common is in a gene called Notch, as in notch on your belt.
N-O-T-C-H?
N-O-T-C-H. And the other gene that is sometimes found is a gene called MYB, M-Y-B. And so I've asked that the tumor that was removed be sequenced in order to look for these mutations. They're not particularly useful to inform your therapy at this particular time, but they do have some bearing on prognosis. I'm going to stay away from that. And they do have potentially bearing on treatment in the future, should that be needed. So the modern workup of this does include some molecular analysis, although candidly, the molecular part of therapy for ACC is 20 years behind lung cancer and breast cancer, for that matter, a number of diseases that we take care of. So the medical oncologist really plays a very small role in this disease. It is a surgical disease, which means that you always try to remove it. Your disease has been removed to a large extent, but not enough. And the issue here is that the windpipe is the windpipe, and we can't make a new one for you. So we can't take your windpipe out. Nevertheless, I have put you on for discussion tomorrow morning at our tumor board, where there are thoracic surgeons in attendance, to just get their input on whether there is any kind of surgical option that might be employed in your particular case. Again, I don't think so, but it is very important to ask that question. Remember, I'm not a surgeon, and I've never done one of these operations in my life. So we're going to rely upon experts, and I'm consulting them tomorrow, and I'll follow up with you depending on what I learn. I think they're going to say no further surgery because it's not technically possible, and instead radiation therapy. Radiation therapy is typically done either with a head and neck radiation oncologist or a thoracic or chest radiation oncologist, remembering that this territory is kind of in between the head and neck and the chest. And so I'll get a consensus at tomorrow's meeting on who would be the best person to do this. In general, it's usually the thoracic oncologist, but I will follow up with you again and let you know which radiation oncologist is thought to be the most appropriate. And from that point on, everything gets a little murky. So the number of cases is sufficiently small that even at the largest cancer centers, including MD Anderson, Sloan Kettering, and the like, when people describe their experience with ACC, they usually are describing 5, 10, 15, 20 patients accumulated over a period of 20 years. And they describe what they did and how things turned out. If you ask yourself how many of those patients had tracheal ACC, the number is vanishingly rare. And so what we do is we just lump everybody together into this category of ACC. And so whether it's originating in the salivary gland or the palate or the trachea, we just treat everybody the same way, because ultimately what matters is the disease itself, which is this entity called ACC. And there is some information from some of the series that have been published that adding a chemotherapy drug to the radiation works better and makes the radiation more effective and makes it therefore less likely that there will be a reoccurrence in the windpipe itself. In other words, where it started. And the drug that we use most of the time for making radiation work better is cisplatin. And the way we give cisplatin is typically weekly. And although it sounds terrible, weekly cisplatin, as chemotherapies go, is not bad at all. As far as side effects are concerned, they really have become quite manageable. There was an old-fashioned way of giving cisplatin that we don't do anymore, which was to give it once every 3 weeks at a very high dose, which caused a lot of nausea, vomiting, deafness, etc. And given weekly, the side effect profile of the drug is really dramatically improved. So where I think this is going to go is a course of radiation therapy, probably over 6 weeks or so. Weekly cisplatin on 1 day a week. It's an intravenous infusion. And then you would go into follow-up, which would likely consist of either CT scans or MRIs, probably CTs because it's in the trachea, it's below the jawbone. So probably CT scans both of the neck as well as the chest. And now that we have the PET scan and the chest CT, and knowing that this disease appears to be confined to the windpipe, we are trying to do all of these things with the intention of curing you. We cannot guarantee at all that we can do that, but that is going to be our approach. And I'm just tipping my hand. I think it's going to end up with radiation therapy and chemotherapy. I doubt that we'll be going down the surgery lane. And just a couple of final comments. Clinical trials. So clinical trials for this disease are quite rare, few and far between, and they are inevitably aimed at people who are incurable. So they're for people whose disease has metastasized, spread to other parts of the body, where attempts at curative therapy no longer exist. Memorial Sloan Kettering is a place that reliably has 1 or 2 ACC trials going at any given time, but they're for people with stage 4 disease. Targeted therapy is in its infancy. There really is no proven targeted therapy. Immunotherapy does not work. And so if immunotherapy is going to work for this disease, it's going to require different immunotherapy drugs, just a very, very different approach from what we do with the regular head and neck, lung cancers, and so forth. So that's the bulk of what I wanted to tell you, and I'm sorry that I spoke quickly. I tried to speak clearly.
You did.
So that you could get all the highlights. What did I leave out? What are the things that are still on any of your minds?
I had a question. This is Chris. So surgery, I know we had talked about surgery March 3rd. Are you saying that you wouldn't do any surgery? Or not you, but there wouldn't be any surgery?
You're talking about Dr. DiBardino?
Correct.
So he's not a surgeon. So he's a pulmonologist. He's an interventional pulmonologist. When I'm talking about surgery, I'm talking about definitive surgery, cancer surgery. Your daughter can explain to you, cancer surgery involves removing 100% of the tumor, and usually with a margin. In other words, with a little bit of clearance around it. So that's not something that Dr. DiBardino would do. Removing part of your trachea would be major, major surgery.
Got it. Because they did mention about on the 3rd going back and doing
An ablation?
ablation.
Yeah, so again, that's a physical local therapy. Ablations are done with heat, they're done with light, they're done with cold, they're sometimes done with alcohol. So what he's doing is he's going back in and taking a look at the area now that he has rescued you and you're breathing normally, and wants to see what is there. And this is one of the points of discussion for tomorrow, I think, is what is the best way to get rid of this disease once and for all? Is it an ablation, or is it something like a killing therapy like radiation? I can assure you that there's no consensus on the best way to do this. Suffice it to say, we are going to and we need to do something, because we can assume that Dr. DiBardino, well, we know Dr. DiBardino got in there and he did what's called debulking. So in plain English, he removed most of what he could see. His goal at that time was to open up your airway so that you didn't have a respiratory arrest, because the clearance was very narrow between the tumor and the wall of the trachea. Well, what the next step is, you coming back?
Kathy, come back.
Sorry, I'm just getting rid of my phone.
Oh, I was like, Mom, what's wrong? Oh my God.
It's in the bathroom and the door's shut.
It's a little scary when people just get up and leave.
No, I'm with you.
So remember, I'm meeting you today for the first time. Your treatment was, initial treatment was just done, I think, just a couple of days ago. And you are on for discussion for the tumor board for tomorrow. We will come up with a consensus on the best approach, with our goal being to remove this once and for all, and what is the best way to do that.
Yes, I think Dr. DiBardino thought that, if they wait 6 weeks to go back and do an ablation, they can see if the cancer grew anymore. And that, I forget his name. I think he's chief of thoracic surgery. It's Dr. K something.
Dr. Kaharchuk.
Yeah, he was going to be there and present to see if maybe they could remove, he talked about a really extensive surgery, removing her right lung and part of the trachea. So they were going to evaluate her during the endoscopy to see if that could be possible.
Yeah, and so that's why I put the case on for the tumor board discussion tomorrow, because Dr. K. Kaharchuk is part of that discussion, and it really is a four-way discussion between surgery, interventional pulmonary, radiation oncology, and to some extent medical oncology. So the goal over the next couple of weeks is to coordinate all of that and come up with the best approach. But you're exactly right. A definitive cancer surgery to remove this tumor once and for all is actually easier said than done.
Yeah, I would say so. And so going back to the mutations that you said had been identified recently, did you say for Notch and MYB, is there any actionable treatment
No.
based on those mutations? Okay, so that's more just for prognosis.
Dr. Alan Ho, H.O. at Memorial Sloan Kettering, is doing clinical trials of a Notch inhibitor for recurrent incurable disease. That's really the first targeted therapy for ACC in history. Is it working? Not really. But that's what we have so far. So people have latched onto this target, which is present in about a third of cases, and are trying to use it as an opportunity for drug development, but it's very much in its infancy.
Okay.
Would not be suitable at all for misuse.
Yeah.
I had a basic question. How do I ask this? The event, was there an event that happened that caused this, or is this just like a DNA makeup situation?
This is random bad luck. So remember, it's very rare. 330 million people in this country. We've got a couple of thousand cases of this every year. So there's no history that leads to this, such as stuff that you ate, stuff that you drank, cigarette smoking, radon, who your parents were, where you grew up, or any of that.
Got it.
We don't have the answer to any of those questions. Also, it's not a disease that runs in families, so it's not something that you're going to pass on to your children. It's also not part of the cancer family syndromes that we have, where people get clusters of lung and breast and colon, colon, breast, ovary cancer that run in families. This is just random bad luck. I have never ever seen a mother-daughter pair with ACC. There's
Thank
always a
God.
first time for everything, but I've never seen that.
Okay.
More common in men than women, or too small a sampling size?
I think it's more common in women. It seems to be more common in women. I have taken care of 6 people with tracheal ACC, and only one of them was a man. The others were women, or are women.
So that's 6 patients over how many years?
10 years.
Okay.
So based on
My clinic, you think it's an epidemic, but it's extremely rare. Most doctors have never ever seen a case.
So I would assume that you learn as you go with the limited number of people that you have ever tried, like you're doing for me, to, keep me going here. I'm thankful to those that came before me because they're giving you information that maybe
Absolutely.
will apply to me.
Yeah. And we use that. So doctors have written up their experience with ACC, and we all use that to try to take care of the next patient. Because this is not a situation, as your daughter can explain to you, where we're ever going to have randomized trials. We're not. Or large series with 100 patients. We're not. It's just too rare, and it's too few cases spread over too many years. And also, around ACC, the good news is the disease grows slowly most of the time, not all the time. The bad news is the disease grows slowly. So when you have a very, 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 very slow growing disease, kind of hard to tell that you're making a difference. Sometimes it's like the disease has a mind of its own and it just does whatever it wants, and you try this and you try that and it ultimately makes no difference. The whole thing just runs its course over 10 to 12 years, and it's as though the doctor was never there. So it's a baffling disease, and it's proved to be very, very difficult to study.
Okay, so next steps?
Next steps are, and this case really merits it, a genuine multidisciplinary discussion among interventional pulmonary, thoracic surgery, and radiation oncology to determine the best approach to get rid of this.
And Mom, I don't know if you do you have more, I don't want to get into more questions if you feel like this is enough information for you. But I mean, do you feel like you have more questions about the course of the disease, or Dr. Cohen's experience with his patients? I mean, I think it's great that the intention is to cure, at this point. Do you feel satisfied with that answer?
I do, but I mean, how does where does this conversation go? I mean, when we go ahead, please.
We follow up with you. So
Yeah.
I follow up with you and I tell you the consensus, because I'm not a person that does ablations, and I'm not a person that does surgery, and I'm also not a radiation oncologist. In that respect, I'm actually the best person to talk to you because I'm an unbiased observer. I'm not going to be treating you with any of those modalities. So I'm kind of the referee. And can listen to the pros and cons from each side. And we're actually pretty good at coming up with a consensus in challenging cases, or cases where there isn't a lot of individual experience. There's a collective wisdom we try to draw on. So I'll share with you the consensus and where we ended up, because our goal and your goal are exactly the same. We want to get rid of this disease. We would like to cure you, and we would like to do it with the minimum amount of damage to normal parts of your body.
Okay. Megan, what are your questions for Dr. Cohen?
Well, I mean, I see the picture now and I totally understand everything. I guess my mind is always going towards the future and what would happen next, what would happen if, I mean, the intention is to cure, but what if the next scan, or a few years from now it shows up that the cancer is back in the same area of the trachea, or it's spread to the lungs? What happens then? I don't know if you want to talk about that, Mom, or...
That's okay. Sure.
Okay.
So unfortunately, we have experience with all of these scenarios. So it is not inevitable that it will come back, but certainly there are instances where it has. So for example, if it were to come back, let's suppose, here's a hypothetical, it's actually a real story. So let's suppose that you underwent debulking surgery, you underwent a course of radiation, there was even some chemotherapy in the mix, you had a bronchoscopy, somebody looked inside and said, oh dear, it's back. So what we did under those circumstances is we went back and we did something very, very fancy, an obliteration technique known as cryospray. We actually went to another university to get that done. And that was 1.5 years ago, maybe almost 2 years ago, and the cancer hasn't come back since. Does that mean that I cured her, we cured her? I have no idea. She's watched closely, she looks and acts completely normal. I hope she's good to go. We've had other people where we had a lung nodule come back, or 2 nodules or 3 nodules, and we went after those with radiation therapy. One of the things that's missing for ACC is chemotherapy. Chemotherapy does not work. So chemotherapy, unlike for most of the other diseases that I take care of, plays very, very little role. There really isn't any good chemotherapy. So what I would be doing in the event, for example, that there were dozens of lung nodules, I would be looking for a clinical trial, probably starting with my friends in New York, to whom I have referred multiple patients over the years.
I do have lung nodules. I've had and I've been told they're benign and they stop looking at them.
That's correct. So you've had lung nodules that go back to 2015 or 2016, and after looking at them multiple times, they declared victory and said that they're probably nothing. And they probably are nothing, because if they're ACC, they usually grow. They grow slowly, but they grow. But what we're talking about here would be new lung nodules.
Understood. Okay. Well,
Now,
anything else?
yeah, I think you said, what was the last scan you had of your chest? Or
Just 3 weeks ago?
A month ago.
a month ago?
3
Okay.
weeks ago.
Okay. So that's
You had that done at Larchmont Imaging.
right, and that's good enough to work with. So right now,
Yes.
okay,
Yeah, that's sort of a baseline. Things at ACC typically happen slowly, so we tend to get scans that kind of match the pace of the disease, which means every 3 to 6 months or something like that, at least to start. No, there would be no need to get another, and you just had a PET scan, which also includes a CT component. So there would be no need to get another scan on you until the summer.
Okay, if you don't mind, just and we won't hold you beyond what's reasonable. For me, as a patient having radiation, where is that radiation going? Is it in my neck? Is it where is it? Okay.
In your windpipe, aimed at your windpipe.
Okay.
It's aimed at where it probably will be what we call a postage stamp field, which means relatively small and rectangular. And what it will do is encompass where the tumor was and some margin of 1 centimeter or 2 around it. So it will not be a gigantic radiation field, which you sometimes have for large lung tumors, or frankly, even for tumors in the back of the throat. This would be relatively more restricted. And yes, that's where the radiation would be going to that particular site in an attempt to try to kill the cancer.
Okay.
no, it's interesting you pointed to the neck because we understood it was in the trachea, more towards the breastbone, is where the tumor was. Is that correct?
Yeah, I should be pointing here.
Okay.
And the trachea, this is your larynx here, your Adam's apple, and the trachea starts just below that, where this little notch is in your neck, and yours was in the distal, or the part of the trachea that was closest to where the 2 big airways diverge and go into the right lung and the left lung.
Gotcha. So it's
But
at the
it's in the trachea.
okay.
Thank you.
And just a quick question about the cryospray therapy. Is that only for recurrent tumors?
That's a good question. I don't know the answer to that question. I would have to direct that to the cryospray expert, who is an interventional pulmonologist at another institution.
Okay.
Our interventional pulmonary people referred her to him.
Okay, gotcha. And do you know where that was?
Temple.
Temple. Interesting. Okay.
I must say, I would not use. Don't think I would use cryospray as my initial therapy.
Okay.
Because the cryospray is a very superficial technique, and these particular tumors that recurred here were very, very, very superficial. They weren't particularly deep. So the cryospray is more of a surface type of treatment. This is part of what needs to be discussed at our conference tomorrow with Dr. DiBernino.
Okay.
And Dr. K.
Yeah, and then assuming that she's going to have the, the chemo radiation, how soon after would you want to do a scan? And then, like, what would the scans look like after that point?
Well, they would be done about every 3 to 6 months.
Okay.
And if they decide that's the route you're going after tomorrow's board, would that happen within a week after that? A month? Or when would that start?
Very soon.
Okay.
There's no reason to wait.
I'll
Right.
clear my very busy schedule, which is nothing. Oh my gosh. Okay. Well, I'm all
I think-
yours.
Yeah, and just to be clear, I realize that I'm conveying some uncertainty, which is deliberate, about what the best approach is. I want to keep an open mind. The patients that I've treated in the past have, for the most part, been treated with radiation therapy and chemotherapy, and then have gone into follow-up. There are other doctors involved here, and many times that I see somebody, the big decisions have already been made. And so the patients have come to me and somebody else has already decided how to treat them. We have the opportunity to do it from scratch and to try to get it right. So I want to be very, very respectful of the other members of the team and try to come up with a really thoughtful consensus for you. Because this is not something you can look up in a book. You cannot look up in a book and it says, here's how you treat Ms. Hughes, you treat her with X, Y, Z. Those statements simply don't exist.
And so if she were to start treatment, so is she not going to get the ablation then?
I don't know. That's for Dr.
Okay, that's still under, okay.
Yep.
And then, we were like, I would love for, her to get a second opinion. Just because it is such a rare cancer, but, I don't know if you would recommend that or if she should go to Memorial Sloan Kettering or, I was thinking about contacting the rare tumor clinic, at UCSD, but they do they look at all the mutations and it just doesn't really seem like that would even be beneficial.
That's going to be low yield. And I think the problem with the rare tumor clinic everywhere is that it's aimed at people with advanced incurable disease.
Yeah.
Not what we're talking about here.
Yeah.
If Ms. Hughes gets a second opinion, it should be with a surgeon.
Okay.
Because I think that's the big question.
Yeah.
Is whether and what kind of surgery is feasible. And I think it needs to be a surgeon at a very large cancer center. Though it has to be at a place like Penn, which is a large but not huge cancer center, or Anderson, or Memorial. It's a very short list.
Okay.
And why is that? Because those are the only places that see enough cases that you have anybody with any experience.
Yeah, and it would have to be a thoracic surgeon, you think?
I think given the location of this, yes, just like
Mhm.
Dr. K is a thoracic surgeon, it would need to be a thoracic surgeon.
Okay.
Because it is below the clavicles, so it's a thoracic surgeon.
Can you speak to for the therapy that potentially Cathy would get? Is this something to impact her day-to-day activities? Is something You mentioned coming in was a week, every 3 weeks, was it, or every week? I can't recall at the beginning.
So radiation therapy is daily, Monday through Friday. It's for about 6 or 7 weeks. Main side effects of that is that it makes you tired. Your esophagus is also in the way. So people do get inflammation of the esophagus, which can at least temporarily cause food to stick and become somewhat painful to swallow. Usually does not result in a feeding tube or anything like that, but certainly is an issue.
Mm-hmm.
It's a lot of ice cream
Yeah.
cones.
It can be hard. I know that patients with radiation, the head and neck patients definitely have a lot of side effects. But it sounds like, Mom, yours is going to be, they're going to give you medication, nausea medicine, and, you might have difficulty eating or difficulty swallowing. But it is, a short-term thing, and you're going to get through it. So,
I know.
It's not like head and neck radiation where the inside of your mouth is getting radiation.
Yeah.
This is a very, very different experience.
Yeah.
It's fatigue and it's some esophagitis, but it's usually manageable with omeprazole, frankly, and maybe minor dietary modifications. And it's temporary for a month or two, but as I said, it doesn't result in profound weight loss, feeding tube, etc.
And this will be done right at Penn.
Yeah, I know. I actually have a OBGYN, Dr. Wanda Ronner at Penn in Cherry Hill. I don't know whether or not I would come to Philly for these treatments. What would you recommend?
So that gets into radiation oncology questions.
Okay.
So I think the way this should work is that if we're going to go down the radiation path, the radiation oncologist making the treatment plan should be here. There should be a discussion. There should be a discussion of protons as the radiation method that might be used. There's a lot of ways that plans can be developed at one place and implemented at another within the Penn system. So where you physically get your treatment is not important. What matters is who designs the treatment. I think that should be done ad hoc.
Okay. We'll be where we need to be. You'll just tell us. Okay. Anything else?
Yeah, we're just across the bridge in Moorestown, so we're not far.
Okay. Yeah, you're right across the bridge.
What's that, Mike?
There isn't a quicker way for my mom to get the COVID vaccine, is there? She's just signed up through this. Okay.
No, the way you're 64 years old, so you should sign up. You can sign up on My Penn Medicine. So there is a sign up that was activated last night. And so you can submit your name and your disease and everything else. And so this is a don't call us, we'll